Hello, everyone. Let's get started. Okay, today what we're talking about is insulin now. Let's get started with insulin. High yield, very high yield. Okay, so insulin synthesis is also very high yield, although it looks like it's not, but it is very, very high yield. So let's talk about the synthesis now. Here, the insulin synthesis, we have, first of all, we got to know that the formation is pre-proinsulin, which start the synthesis in RER. So before that point, let's just mention one more thing, that in the pancreatic beta cell, remember, pancreatic beta cells, the nucleus of these cells are going to form insulin. And from the nucleus, that insulin mRNA will go down to the RER. Well, when it goes to the RER, in the RER is in the form of pro-insulin, okay, in the RER. And what's going to happen is, okay, wait, so if you can hear me, just let me know so I know that everything is perfect. And if there is any problem, do let me know. And you can always write in this chat here, okay? So what I just said, let me just repeat quickly, because I don't know if the mic was on or. So, okay, we're going to talk about here the insulin. Let's start with insulin. Insulin, simple thing, okay? What we have is, if you recall, the pancreatic beta cells, these pancreatic beta cells are going, the nucleus of these pancreatic beta cells are going to form insulin mRNA. That insulin mRNA will travel to the RER in the form of pre-pro and forms into pre-proinsulin. This pre-proinsulin then gets the cleavage of pre-signal. So this pre is going to be, there's going to be cleavage of this pre-signal, and it's just going to form into a proinsulin. Okay. And once the proinsulin is formed, what's going to happen is this proinsulin will go into the Golgi apparatus and stored it. So wait, let's read it here first. So proinsulin stored in the secretory granules. Then there's a cleavage of proinsulin leading to exocytosis of insulin and C-peptide. Although, okay, let's just, since they haven't mentioned, so let's just talk about each one of those things. Let's put it one more time here. Simple. So in the RER, we said it's a very high yield. Look, in the RER, we're talking about pre-pro insulin, right? And there was a cleavage of this pre-signal within the RER. And when it goes out of the RER, it's going to be just a pro-insulin. And this pro-insulin is it goes into the Golgi apparatus. Let's just put Golgi apparatus. And within the Golgi apparatus is going to pack this proinsulin, okay, into secretory granules within the Golgi apparatus, okay. Then from when, let's say this is the package of proinsulin, okay. From here, what's gonna happen is, from Golgi apparatus, these secretory granules are then going to go into the cytoplasm. Now, there's something that's going to happen within these secretory granules. What's going to happen is, we have specific enzymes known as endopeptidases. So that's important enzyme. So let me just write it here. Endopeptidases. Within these secretory granules, what they are going to do is they are going to cleave, these endopeptidases are going to cleave proinsulin into two things, all right? So proinsulin into two things. And that will be, first you have insulin, which we need, right? And second thing is going to be, you're going to get C-peptide. C-peptide. So if you read from here in the first aid, what we have is both insulin and C-peptide are increased in endogenous insulin secretion. Example, type 2 diabetes and insulin secretagogues or insulinoma, whereas exogenous insulin lacks C-peptide. And I'll talk about that, what they were trying to say here. But let's go a step back again and let's recall the whole thing we talked about. So we said the very high yield that beta pancreatic cells, nucleus, they are going, it's not a neutrophil, it's a nucleus, it's a short form, okay? Within the nucleus, what's going to happen is we are releasing what? Insulin mRNA. mRNA. So now with that, we have a full story. So let's talk about it. So insulin synthesis, pancreatic beta cell, we form insulin mRNA. That insulin mRNA is going to the RER. When it goes into the RER, there is a pre-pro insulin formation. And that pre-signal, there is going to be a cleavage. RER, which is rough endoplasmic reticulum, will cleave the signal peptide, which is the pre, and leading to formation of just the proinsulin. That proinsulin will go into the Golgi apparatus, and in the Golgi apparatus, all the Golgi is doing is packing that proinsulin. It's going to pack that up and send it to the cytoplasm. So Golgi is going to pack up in these secretory granules and send it to cytoplasm. Now, within the secretory granules, these small granules, we have an enzyme. The enzyme is known as high-yield endopeptidases. Endopeptidases. What this endopeptidase is going to do is going to cleave this proinsulin further more into two more things. The first thing is the insulin, and the second thing is C-peptide. So whenever we have the release of insulin endogenously, meaning within the body, we always have a C-peptide coming with it. Simple as that. So this first aid here is trying to say, okay, when you have endogenous secretion of insulin, of course, you're going to have a C-peptide. So this is one of the things we can check clinically. If the insulin is high, either the C-peptide is high or not. If it is high, then say, okay, man, this is coming straight from pancreas. But if there is just insulin without C-peptide, this helps differentiate factitious hypoglycemia, that someone is taking insulin from outside. It's not due to insulinoma. It's not a secretagogue or insulinoma. It's something else. Okay, I hope that makes sense. Now, the second thing is insulin is synthesized in pancreas and cleared by both the liver and the kidneys. Okay, great. Now, let's also look at the structure, which is also high yield. So in here, the structure, we have insulin. Look at the insulin. So this is just the insulin part, which is connected by two disulfide bonds. So disulfide bonds. Okay, that's the insulin. And look at the C-peptide. This whole thing is just C-peptide. And the whole thing is called proinsulin, and eventually is going to form just insulin C-peptide. Right. Now, one other thing is that when we are trying to check the levels of insulin, we actually look for C-peptide. Why is that? So we do check for the, let me do one thing here. Okay. We do check the level of C-peptide because it has a higher, or a longer, I should say, half-life. So it has a longer half-life than insulin. Okay, that's one thing. And we measure this as an indicator for insulin secretion. Simple, right? So if we have a C-peptide high, that means for sure we're going to have a lot of insulin. No question about it, right? And because insulin, as insulin C-peptide, because the C-peptide does not undergo significant first pass metabolism. That is why we have a longer half-life. So it circulates. The C levels are going to be higher because it doesn't have, again, the first pass metabolism. And that is pretty much it for this synthesis. Yep. Okay, so let's go on with function now. Now the function, let's change color. Now the function is insulin. It's pretty easy. Okay, it binds insulin receptor, high yield. What receptor it binds? Tyrosine kinase activity. It binds to the tyrosine kinase, causes inducing glucose uptake, which is a carrier-mediated transport, which we will talk about in the other right side. So it induces glucose uptake into insulin-dependent tissue. So what is it doing? It's binding to insulin receptor, causing the glucose uptake into specifically insulin-dependent tissues, and we'll talk about those, and causing gene transcription. Okay, insulin is an anabolic hormone, causes anabolic effects. So that is, you have increased glucose transport in skeletal muscles and adipose tissues. Right, the main thing is you're trying to have that all glucose from the blood, sending that into tissues. The insulin doesn't want glucose to be there. Okay, so look, causing increased glucose into skeletal muscles, adipose tissue, causing increase in glycogen synthesis and its storage, causes increase in triglyceride synthesis. So you're taking a sugar, a carbohydrate, but it causes, as sugar goes in there, but you're causing increase in triglycerides, right? The other thing is increase, that this is also important, that it causes sodium retention within the kidneys, increase in protein synthesis in the muscles for sure, causes increase in cellular uptake of potassium, high yield. So look at this. It causes cellular uptake of potassium and amino acids, but potassium is high yield. Also causes sodium retention. But most important is this, that it causes cellular uptake of that potassium. One thing it is decreasing is it's the other hormone, which is the counter-regulatory hormone, glucagon. For sure, it's going to decrease the glucagon and also decrease the lipolysis in adipose tissues, because all the other counter-regulatory hormones were doing what? Lipolysis, ketogenesis, everything coming to the bloodstream, right? So this guy's like, hey, I'm trying to clean this up and you're trying to mess up with me. So these are two opposite functions than the counter-regulatory hormones, which we did talk about. Okay, so unlike glucose, insulin does not cross placenta. In mothers with diabetes, excess glucose can cross placenta, causes fetal itself will have increase in insulin from their own pancreatic beta cells, high yield. Okay, and in the diabetic mothers, what's going to happen is these patients, these child will go under hyperplasia of those beta cells. So as soon as they're born, they will go into hypoglycemia because they have a lot of insulin and they're not getting glucose. So they will go into hypoglycemia. And this is one of the complications of diabetes, gestational diabetes, okay, which I guess we will talk about in repro. Okay, let's talk about this thing, this right side now. Very important. So here we have insulin-dependent glucose transporters, which is just going to be GLUT4. I mean, you think about insulin, you say, hey, insulin is doing a lot of stuff, right? But here you just have insulin-dependent glucose transporter, only one, which is 4. Insulin independent, meaning these guys, they don't even think about insulin. They're like, hey, insulin, no matter you're here, not there, it doesn't matter. We're still going to take glucose. We don't need you. Okay. But importantly, what you really want to think about is that the GLUT4 is present where? Adipose tissues, striated muscles. But again, in the striated muscles, very high yield point is that in exercise with these skeletal muscles, they don't even need insulin. So an exercising muscle can increase GLUT4 expression, causing glucose to go into these muscles. They don't even need insulin. So one thing that really needs insulin is the adipose tissues, right? Isn't that amazing? That's actually very amazing. Okay, let's take a step back one more time. Very high yield, insulin-dependent GLUT4. Adipose tissue, skeletal muscle, but skeletal muscles and exercising skeletal muscle. Meaning if you're sitting, resting down, doing nothing, these skeletal muscles are not going to put that GLUT4 on the expression on the cell, so you can take up that glucose from the blood into those skeletal muscles. But then at the resting point, you need insulin. But if you are in exercising, if you are moving, then these skeletal muscle, they don't need insulin. They can just put up these GLUT4s, get all that glucose into skeletal muscles, and burn that, right? So let's talk about independent transporters. Independent transporters are going to be GLUT1, 2, 3, except the 4, everything, right? 5, NSGLT1 and 2. So GLUT1, seen in the RBCs, brain, cornea, placenta. GLUT2 is bidirectional, high yield. 2, bidirectional. Okay, beta islet cells, liver, kidney, GI tract. Think two-way street, right? Two-way street. GLUT3 is brain, placenta. 5, fructose. 5 is for fructose. Fructose is needed for spermatogenesis and GI tract. SGLT1 and 2. We have these. These are sodium, glucose, S for sodium, G for glucose, co-transporter. Okay. We have transporter 1 and transporter 2. They are in the kidneys and in the small intestine. So brain prefers glucose all the time, but can use ketone bodies during starvation. Okay, but the RBCs, there's a problem. They can only utilize glucose. They cannot utilize ketone bodies as they lack the mitochondria for aerobic metabolism. They cannot utilize ketone bodies because they lack mitochondria for aerobic metabolism. Well, as for the brain, although it prefers glucose, but does work on ketone as well. So no problem there. And the RBCs just use glucose. Okay. What else we can talk about, which might, okay, yeah, let's talk about one graph. Okay, here. So we have a graph, and this graph is going to be about insulin concentration and your GLUT expression. Okay, so as the insulin concentration goes higher and higher, your GLUT4 concentration goes higher and higher. GLUT4 specifically, GLUT4. But what is going to be constant? You guessed it right. That's going to be insulin independent GLUT transporters, which is going to be all of the rest of GLUTs. For example, GLUT 1, 2, 3, 5. Not the 4, the rest of them, right? So this is sort of a graph that you will see with insulin concentration. So let me just do the highlighting part. So as the insulin concentration is growing, all you will have the expression of is GLUT4. But the constant are going to be all the other GLUT transporters, which are not dependent on insulin concentration, as you can see in this nice pretty graph, right? Okay, and that was important. Other than that, let's talk about a little bit of this glucose itself. Okay, so glucose, where are we here? Okay, this GLUT4, it is stored in cytoplasmic vesicles, and under the influence of these guys, they're just stored in the cytoplasmic vesicles, and they don't show up on the surface of cell membrane. But when there is an insulin, when you have insulin, or when you have exercising skeletal muscles, they are going to cause these vesicles to go up into the cell membrane and cause the expression of these GLUT4s, so they can catch up the glucose and take them up within the cell. Okay, that's the GLUT4. let's talk about one thing about insulin. Insulin, not my bad, insulin, but glucose. Glucose goes from a higher concentration to lower concentration, okay, with the help. So glucose need a transporter, which is your GLUT, all the GLUTs, right? GLUT family acts as what for glucose now? Facilitated diffusion. So glucose needs GLUTs, which are the transporters. So glucose needs a facilitated diffusion. It's not it doesn't just go right away into the cell without these GLUTs. It's a facilitated diffusion. They go through facilitated diffusion, but no energy is required, but needs a carrier protein, which is the GLUT. So glucose does not need energy, no energy, meaning no ATP required, but they do require, glucose requires GLUT transporters. Okay. And these GLUT transporters, they have a preference for D-glucose. That's just a lower yield thing, but forget that point. Then what else we have? Okay, I guess that's pretty much for the glucose. So here we have brick lips. Insulin independent glucose uptake is taken up in the brain, RBCs, intestines, cornea, kidney, liver, islets, beta cells. So pancreatic islets of beta cells, right? Placenta and spermatocytes. Maybe an easier way would be that you just remember insulin dependent ones, which are just adipose tissue and skeletal muscles. And the rest is just insulin independent. But who knows? If you want to memorize this, that's great too. Okay, let's talk about the regulation. Okay, now regulation of insulin is glucose is the major regulator for insulin release. Okay, again, glucose is a major regulator for insulin release. Increase in insulin response with oral versus IV glucose due to incretins, example, glucagon-like peptide 1, GLP-1. So they're saying simply that you have increased insulin response with oral glucose. Although if you think about it, you say, hey, I am going to have some glucose orally, it will take a longer time to go into the bloodstream and cause the pancreatic beta cell to release insulin, but that's not the case. Versus, I'm just giving you an example, which is right in there, that you say, hey, if I give you glucose in IV, it's just going to go straight to the bloodstream, cause insulin release, which makes sense. But here, it's a little different. Hormones work a little differently. Why? Because we have something known as, if you did your GI, you had something known as GLP-1, glucagon-like peptide 1, your incretins, and also your glucose-dependent insulinotropic polypeptide, GIPs. So GLP-1s and GIPs, which are released after meals, and these guys, they go to the pancreatic beta cell and cause increased beta cell sensitivity to glucose, causing release of insulin faster orally than if you give IV. Again, what we talk about, high yield point, that if you were to give an oral glucose, okay, what's going to happen is this oral glucose is going to go to GI and going to stimulate these hormones known as incretins, which are GLP-1 and GIP. These guys are going to go straight to the pancreatic beta cells and cause increase in beta cell sensitivity to glucose. So if only one molecule of glucose hits the beta cells, it's going to secrete 100 insulin molecules. I'm just giving you an example here. That's sensitivity being increased, right? Versus that if you were to give someone IV glucose, now whatever glucose reached the beta cell is going to secrete insulin based on the levels it reached, based on the level they have reached to the pancreatic beta cells, they will release insulin. So for example, if let's say 10 molecules insulin release, maybe you have 10 insulin. I'm just giving an example, okay? This is not how it works, but giving an example that the IV will not lead to release of insulin. IV glucose will not cause a lot of insulin to be released as comparison with your oral glucose, because oral glucose go to stomach, stimulate incretin, GLP-1, GIP, which increase the sensitivity of the beta cells to the glucose. So even if one molecule of glucose can secrete a lot of insulin. Okay, so here increase in insulin response. So summary, increase in insulin response with oral versus IV glucose, period. Okay, so let's talk about now the release. The release is decreased by, so insulin release is decreased by alpha-2 stimulation, and it is increased by beta-2 stimulation. So 2 equals regulates insulin. So all the 2's are regulating insulin. Alpha causing the insulin to go down, and beta stimulation is causing the insulin to go up. Okay. But now the question arises, if we have alpha and beta receptor, right, to cause the insulin release, but what's happening normally and which one is dominant? I mean, if you get the epinephrine to work on both, so what's really going on? Are we getting any insulin, or the functions just cancel out? Well, the thing is, insulin, the dominant effect of the epinephrine is to stimulate alpha-2. So this is the dominant by epinephrine. So the alpha-2 stimulation, which causes decreased insulin release, is the dominant effect of epinephrine. Okay. But if you block, now the question arises, if you were to block this dominant by giving alpha-2 blocker, then what's going to happen? Now you are causing epinephrine to work on the beta-2 and causing increase in insulin. Right? Amazing. Okay. And that is what we have for the regulation. Now the next thing is glucose enters the beta cells, and it leads to increase in ATP generated from the glucose metabolism. So when we are reading this, let's also take a look at this picture. Okay. So picture 3, point 3 here. So here is the GLUT2. We said 2 is bidirectional. Okay. So glucose is taken up by GLUT2. Where? Look at the insulin pancreatic beta cells. Right? So that glucose goes in, and then when the glucose goes in, again, this is facilitated diffusion by GLUT2. And this glucose goes in. Once it is inside the pancreatic beta cell. Now the whole thing we're trying to talk about here is how glucose is going to cause stimulation of insulin release. Okay, that's the main idea here. So, and now the small steps, how it really happens is as follows. So we have glucose that goes in. That glucose goes in and goes into glycolysis within the pancreatic beta cells. Glycolysis causes increase in ATP production, right? There's an increase in ATP. That increased ATP, which are these molecules there, those are going to cause ATP sensitive. They're going to go on these channels, potassium channels. When the ATP gets bound to these channels, they will close. So potassium gets closed. When the potassium gets closed, the cell goes into depolarization. Let's actually read before I mess up something. But here, you have these beta cells, leads to increase in ATP production. We get that from this point. And this closes, yeah, I was right. Okay, this closes the potassium channel, right here. As soon as these ATPs get bound to these channels, they will close this channel, which also, as a drug, sulfonylureas do the same thing. They close these channels. And once these channels are closed, there is going to be a depolarization. That depolarization of the beta cell membrane is going to happen, and that is going to cause voltage-gated calcium channels to open. These guys will open, which is voltage-gated calcium channels. Now, the calcium is going to come inside the pancreatic beta cells, and once we have calcium influx, there's going to be stimulation of insulin exocytosis. That increase intracellular calcium is going to cause what? Exocytosis of insulin granules. And you can see how they are just going out of these pancreatic beta cells. They go into bloodstream and cause their action. Okay, now let's go back let's talk about one thing here, which we need to address, which is ATP sensitive potassium channels. These ATP sensitive potassium channels, normally at a normal level, these are open at rest. So when they are open at rest, you are not causing depolarization. So no calcium is coming in, no insulin being released, because they're open. They're open, meaning more and more potassium is going out. So you're not going into depolarization. Okay, when they're open at rest, it allows again the outward potassium current, which maintains the membrane polarization. But when the ATP gets bound to these channels, from this channel, what's going to happen is you will have a decreased efflux of that potassium, and that is going to cause membrane depolarization. Okay, why is that happening? Because when you have increase in potassium inside the cell now, because they're not going out, it leads to increase in resting membrane potential in the cell, and that causes membrane depolarization. Okay, and this membrane depolarization will cause these calcium channels to open, so that the calcium can go in. And then when the calcium, there's influx of calcium. An important point here is going to be about that calcium is going to cause exocytosis. Now, one important point is going to be about something, again, GLP-1 and GIPs. Actually, just GLP-1s. So let me write this down here. GLP-1 receptor. So there's a receptor on the pancreatic beta cell that is for GLP-1, which is right here, glucagon-like peptide 1. Okay, so glucagon-like peptide works on this channel, which works through adenylate cyclase, causes increase. This is high yield, causes increase in cyclic AMP. And that increased cyclic AMP leads to exocytosis of these insulin granules, which is just normal function of calcium. So you see how GLP-1s are again irrespective of glucose levels, of anything. They're just going on the pancreatic beta cell, causing more and more insulin release. Okay. No wonder there's a weight loss with these drugs. I mean, and these are right now the top drugs for obesity, diabetes, given subcutaneously. And you can look up online. And the function is simple, that they're just going to cause more and more insulin release, directly working on the pancreatic beta cells. Okay. So yeah, that's pretty much what we have for this one. Now, we said one more thing here for sulfonylureas, high yield, that okay, let's just make a simple thing here. We talked about here the GLPs, and we're going to talk about GLP-1's receptor, and we talked about sulfonylurea. sulfonylurea, what's going to happen is if you give someone sulfonylurea, which we'll talk about in pharmacology, that they don't even look at ATP. What they're going to do, they're going to come in and just close this channel. When they close the channel, the whole thing will just go on its own and cause insulin release. So that's the function of sulfonylureas essentially. Now there's a problem. Now the problem is going to be if there is a mutation in this channel. It's called the potassium channel mutation, for example. It's called potassium ATP mutations. So what's going to happen with this mutation? You will have these channel being mutated. You need what's going to happen with this mutation, that you would need increased affinity. There's going to be increased affinity for ATP. So the closure of channels will cause depolarization and insulin release at a low concentration of blood glucose. Okay, again, let's step back and understand what did I just talk about. Well, there are two mutations in the ATP, potassium channel ATP mutation. One mutation is that it's going to increase the sensitivity for ATP, meaning there is a more sensitive, these channels are more sensitive to ATP, meaning one ATP gets bound to this and they will close. When they close, again, what's going to happen? You have more insulin release. When the more insulin release, guess what's going to happen? Now you have a lot of insulin and not glucose in there, so you are going to cause a hypoglycemia. And because this is a congenital problem, in congenitally, you will see it's called congenital hypoglycemia or neonatal hypoglycemia. Okay, it is the familial form of neonatal diabetes. So let me write it down: familial form of neonatal diabetes. Okay, that's one thing. Now, the second thing what can happen is you have a decreased affinity. As a mutation, you might go into decrease affinity for ATP. So it's total opposite. No matter how much ATP you give here, no matter how much glucose you have here, no matter how much ATP you can produce within the pancreatic beta cells, they will not be able to close this channel. When they do not close this channel, they do not go into depolarization. They don't release insulin. When the insulin is not out, you have a lot of glucose within the blood. Right? High blood glucose levels. So for the treatment of this second problem, you can give sulfonylureas, close these channels, and that insulin can take care of that glucose molecules. Okay. So now with that, let's talk about insulin. So now the insulin is out. The big guy is out. What does it do? All right, so insulin works through tyrosine phosphorylation, okay, and it causes a couple things. It causes vesicles containing GLUT4 to go on the surface, and if you can see they're going on surface, that's one thing. Second thing it's going to cause is glycogen lipid protein synthesis, which is also that glucose is coming down with the help of insulin. It's leading to glycogen, lipid, and protein synthesis, which we talked about how normal mechanism is here. And third thing is going to cause is eventually going to cause cell growth DNA synthesis. Now, the important point is how are these, or the actual important point is going to be how the insulin, or through which receptors the insulin is causing all these effects. So it is causing glycogen synthesis, glycogen and protein synthesis, and vesicles containing GLUT4s to go out on the cell membrane by one pathway, which is called phosphoinositide 3 kinase pathway. So let me just write in a simple word: PI3s. Important, okay? So through PI3, which is phosphoinositide 3 pathway, or phosphoinositide kinase 3 pathway, it's going to cause vesicles to go up on the surface, and it's going to cause protein synthesis, glycogen synthesis. Okay. And one other high yield point is going to be how the way it causes glycogen synthesis is going to be through So it stimulates an enzyme known as protein phosphatase. And that protein phosphatase will cause glycogen synthesis. Okay. And the other cell growth DNA synthesis is due to RAS MAP kinase pathway. So let's just write that down. RAS MAP kinase pathway. And that is going to cause cell growth DNA synthesis. So the important thing here, why I mention all this, is because see, insulin has different actions through different, working through different receptors, not receptors, but to different cyclic channels, not cyclic channel, what are these? These are through different intracellular pathways, like PI3s, like RAS MAP kinase. So very high yield is that you just have to know that insulin, first of all, stimulates tyrosine kinase. High yield. Through tyrosine kinase, it has more function through other signaling pathways. First of all, we have the PI3. PI3 is going to cause a vesicle containing GLUT4 to go on the cell surface. Second thing is going to cause is stimulates the protein phosphatase enzyme, which causes glycogen synthesis, and the rest is just lipid protein synthesis. But this is important. Names PI3 causing all of this. Okay, and RAS MAP kinase causing cell growth and DNA synthesis. Okay, yeah, that's what we have. Now, which one thing we talked about here, let me just put that here, that we have skeletal muscles. That skeletal muscle, when it is exercising, meaning there's a activity within the skeletal muscles, muscle contraction basically, right? So muscle contractions or active skeletal muscle is going to release calcium. And that calcium is, again, putting these vesicles on the cell surface. So they don't need the insulin, which is the point right here. Okay. Okay, lastly, let's talk about one last thing for insulin. Clinical tie-in point, one more. That is going to be that glucokinase. And all of these, the enzyme, everything is also in biochem. But it's a really important point. That glucokinase function as the glucose sensor in controlling glucose entry, right? And insulin release. So glucokinase, as the name suggests, so it is a glucose sensor. Just remember that. Glucose sensor in controlling glucose entry and insulin release. Now, if there is a mutation of this glucokinase, it is known as heterogeneous mutation of glucokinase, And now with that, what's going to happen is, because it was a glucose sensor and all it was doing was, it was a glucose sensor in controlling glucose entry and insulin release. So glucose entry and insulin release, two things, right? So now when you have a mutation here, guess what's going to happen? You will cause higher glucose levels within the bloodstream. And through higher levels, then you will stimulate the insulin release. Okay, that's one thing. Second thing is going to be with the mutation of glucokinase, you have decreased ATP formation that leads to decrease in insulin secretion. Okay, hope this makes sense. And the last pathology that we are going to mention here is going to be that you have something known as maturity onset diabetes of young, MODY. Okay, this MODY which is basically maturity onset diabetes of young, right? Here, all you have again, it's an autosomal dominant. You have, because it's diabetes, you will have a mild hyperglycemia, increasing glucose level, uh, uh, which worsens with pregnancy-induced insulin resistance because it's of young. So it will worsen with pregnancy-induced insulin resistance. So typically, what you will see in this patient is this patient is young and non-obese, although has diabetes. So let me write it here: young patient, non-obese, no obesity, but it has the patient would have the diabetes, and it is this MARI is non-progressive, meaning it's not a progressive disease. Okay, so it's just two tie-ins. Hopefully, you will see that in other resources. But here, simple. We talked about again glucokinase being an important thing, which is a glucose sensor. G for glucokinase, glucose sensor. All it does, it controls the glucose entry into the cell, causing insulin release. So when you have a problem in the glucokinase, guess what's going to happen? You need more and more glucose within the blood to cause insulin release. Simple, right? And that more and more glucose is basically hyperglycemia. That's one thing, and that is known as heterogeneous mutation of glucokinase. That's one. Second thing about MADI is your maturity onset diabetes of young non-obese patient, but has a diabetes mellitus. So you will think about it's an autosomal dominant hyperglycemic patient who is non-obese, and that's about MADI. Okay, and that's going to be all. So let's just quickly review this and move on to the next part. So we did review insulin synthesis, pretty good. Functions, just remember, try to put glucose out of the blood into these tissues. Only two things are decreased glucagon for sure, because it's a counter-regulatory hormone, and decrease in lipolysis. Okay. And then you have what else? A regulation. Remember the GLP-1s and GIPs. These are incretins. And remember your alpha-2 being dominant. You block this out, the epinephrine is going to work on beta-2, causing insulin increase in release of insulin. Insulin works through tyrosine kinase, stimulates PI3, and causes these two functions, which is here is going to be your protein phosphatase, PP, and tyrosine kinase. Also stimulates your RAS, MAP kinase, and that is going to cause cell growth and all that. Glucose comes in, causes increase in ATP, blocks this channel out, which is ATP sensitive potassium channel. Sulfonylurea is doing the same thing, causes depolarization. Calcium comes in, releases the insulin out. GLP-1s are directly causing increased exocytosis of insulin by increasing cyclic AMPs. And that is all for insulin. If you have any question, you can write in the chat box, and I'll be happy to answer anything that you might have. And in about 1 minute, we will go on to the next page, which is adrenals. Okay, great. Um, all right, we have a question. Mutation in MADI. Okay, so here the mutation is again, as I told you guys, is there's a mutation, a gene mutation, which is autosomal dominant in fashion. Okay, only one gene is mutated, causing now. Important thing with MADI is going to be your patient, again, young patient who is non-obese, who is not obese, has diabetes. Okay, and then you think of, okay, it's an it has autosomal, again, it's an autosomal dominant one gene mutation, uh, and you just have a young non-obese patient. Okay, let's move on with the next thing now. That is going to be the adrenals, high yield adrenal steroids, congenital adrenal hyperplasia. Okay, here it's simple. Let's talk about the first thing here. So let me zoom in. So we have cholesterol. Why the STRA? What is STRA? It's a rate limiting step. Okay, great. So cholesterol, it's a rate limiting step in which the cholesterol gets converted into pregnenolone. Pregnenolone, right? So pregnenolone, what there is an enzyme known as cholesterol desmolase. Cholesterol desmolase. Now, who's stimulating cholesterol desmolase? So if you recall, you had the hypothalamus, which is secreting something known as CRH. That CRH, corticotropin releasing hormone, was stimulating the release of ACTH. Now that ACTH and high yield, sometimes they ask you, what is the name? They don't mention ACTH, they mention the proper full name. And this is ACTH is adrenal, simple, corticotropin hormone, simple, corticotropin hormone. Oops, here you go. So adrenocorticotropin hormone, ACTH. Adrenocorticotropic hormone. Okay, that ACTH goes on the adrenal cortex and stimulates cholesterol desmolase that converts the cholesterol. If you recall, we talked about how all the GFRs are made from cholesterol. This is what we mean. So cholesterol comes in and makes all these GFR hormones. And the rate limiting enzyme here is going to be your cholesterol desmolase. And it is stimulated by ACTH. Okay, so when you stimulate cholesterol desmolase, it converts into pregnenolone. Okay, that pregnenolone is going to go into two sides. So you have it's going to go towards the right and goes down. Towards the right, everything on the right side, you will only need one enzyme for that, and that is 17-alpha-hydroxylase. If you look, you have 17-alpha-hydroxylase anytime that you want to make a right. Just got to remember that, okay? Whenever you want to go on the right side, you have 17-alpha-hydroxylase, simple. Okay, so let's talk about here. Pregnenolone, 17-alpha-hydroxylate works on this enzyme, and it converts that pregnenolone into 17-hydroxypregnenolone. Simple. 17-hydroxylase, 17-hydroxypregnenolone. Simple, right? Now, if you think about that pregnenolone being going down into formation of progesterone, same thing. 17-hydroxyprogesterone. No rocket science about it, right? Now, important point is that this enzyme, it's going to be inhibited by your ketoconosoles. So let's just write them. Ketoconazole, conazole, your spironolactone, and your abiraterone or abiraterone. Abiraterone. It's going to inhibit this enzyme, and not only this enzyme, but also your 17 and 20 lyase. So let's just mention that. Here, there's another enzyme. So let's just forget this point here. There's going to be another enzyme known as 1720 lyase, which converts this part into DHEA and also converts progesterone into androstenedione. And the enzyme is 1720 lyase. So these drugs are going to inhibit both of these things. Okay. Now here, we were here at pregnenolone is going to convert it into progesterone. Progesterone by enzyme, which you don't need to memorize, that is going to be your 3-beta hydroxysteroid dehydrogenase. Okay. Don't need to memorize this, so forget that point. Just remember pregnenolone converts into progesterone, and you just need the names. Progesterone then goes down in formation of 11-deoxycorticosterone. Now, if you take a look at this one, it has a part of this cortisol, for example, corticosterone, right? So it's going to have a weak aldosterone. Just remember that this is going to be weak. So again, I guess let me just make things a little simple. We're trying to make, in the first layer, we're trying to make in the zona glomerulosa, we're trying to make aldosterone, right? This section from here onward is just going to end up in aldosterone. So whatever things that we are going to get, for example, this top one, it is going to be your weak aldosterone, simple. But something is going to mess up here, and that is the corticosterone, which you think about it, cortisol is somewhat similar, and this is basically because this is weak cortisol. Okay. And then you have the enzymes are important. Okay, for progesterone gets converted into alpha deoxycorticosterone by 21 hydroxylase, and 11 beta hydroxylase will convert that into corticosterone, and corticosterone finally will make aldosterone. Now, if you look at the last step, you need angiotensin 2. Angiotensin 2 will stimulate your aldosterone synthase enzyme that will lead to eventual formation of aldosterone. And where is this angiotensin 2 coming from? Who's stimulating this? If you recall your RAS system, so renin stimulating angiotensin 2, which then stimulates aldosterone synthesis, high yield. Okay, so this was the first layer, and I'm just going to talk about this first, and then we will see how we can memorize the simple way. So second thing here is going to be, again, your progesterone will convert into deoxycortisol. That deoxycortisol is going to convert into cortisol by 11 beta hydroxylase. And then that cortisol will form cortisone, and you could inhibit that by glycyrrhetinic acid. Okay. Yeah, that's pretty much for the fasciculata, which will make the glucocorticoid, which is the cortisone. Lastly, we have, because we were going right all the way towards the right side, here we have the formation of DHEA first. DHEA will be converted to androstenedione by this enzyme that we said, okay, forget that enzyme, right? And that androstenedione will convert into testosterone, okay? And that testosterone will eventually go out into the peripheral tissues, and 5-alpha reductase enzyme will work on the testosterone in the peripheral tissues, and leading to formation of DHT, which is dihydrotestosterone. Okay. And testosterone will also, when it goes to peripheral tissues, there is another enzyme known as aromatase, which is in the peripheral tissues, as mentioned here as well. And it's going to convert that testosterone into estradiol. Estradiol interchangeably goes into esterone. Okay. And the first part, that was the androstenedione, can also, when it goes into the peripheral tissue, it can also be converted into esterone by aromatase B. Now, you could inhibit the whole enzyme aromatase B by drugs, for example, anastrozole, letrozole, exemestane, okay? And you could inhibit 5-alpha reductase by finasteride, okay? Or let's go a little further, and we say DHT works on your DHT receptors. You could block these receptors by giving a drug, that is flutamide. So you have finasteride, which is blocking the formation of DHT, and you have flutamide, which blocks the DHT receptor, so it doesn't even work on it. Okay. Same way, estradiol and esterone, they also work on their receptor, right? And that receptor, let's just say a receptor here, and you could block that receptor by giving a drug known as tamoxifen, or your relaxafen, Okay, as for the drug purposes, let's just read one more time what we talk about as a drug or high yield. Okay, so you could block aromatase enzyme by these drugs, which is anastrozole, letrozole, exemestane. Important. You could block 5-alpha reductase by finasteride, but you could also block these receptors that the esterone and estradiol works on by tamoxifen, relaxafen. You could block DHT receptor by flutamide. Okay. Now the question arises. Let's just remove all this, and let's talk about one thing here, and that is your androstenedione, right? When it goes into the peripheral tissues, it leads to formation of esterone. And when it is in the, for example, when it goes, but in the peripheral tissues, when it goes, let's say, in the testes, it is converted, the same androstenedione is converted into testosterone in testes. But again, when the testosterone goes into the peripheral tissues, it is converted back into either estradiol or DHT. Okay. What else we can talk about? Okay, one more thing. Finasteride, if you were to give finasteride, which is going to block the conversion of testosterone into DHT, so guess what's going to happen? You are going to cause increased level of testosterone, right? When there's increased level of testosterone, all what's going to happen is those testosterone is just going to go back and get converted to estradiol. So indirectly, you're just increasing estradiol levels. Okay. And that, if you recall, we talk about when you have increase in estradiol, it's going to cause gynecomastia in men due to, again, increase in estradiols. Okay. So one of the adverse effects of finasteride is going to be, again, gynecomastia in men. Okay. So that's one thing. Second thing is about, again, alpha. Let's just actually erase all this and talk about this 5-alpha reductase. So 5-alpha reductase reductase, the mechanism is simple, converts testosterone into DHT, right? Now, there are two types of 5-alpha reductase, importantly. You have type 1 and type 2. Type 1 is present in the post-pubescent skin. So after puberty, in the skin, you have type 1 5-alpha reductase. And type 2, on the other hand, is going to be present in genitals. So one is in skin, one is in genitals. So if you have a deficiency of your type 2, which is present in your genitals, so fine, let's just write it, 5-alpha type 2 deficiency, it's going to cause decreased DHT production, right? Decreased DHT. So testosterone is present, but DHT is not. So what's going to happen, we will talk about that in reproduction, that there will be, because you have a testosterone being present there, you will have internal male genitalia, because there's testosterone there. Male genitalia is internal. So due to testosterone present, internal male genitalia development will be there, and due to alpha receptor deficiency, DHT is not present. So your external genitalia, so DHT is not there. Let's just do it this way, and the external genitalia will not be developed. So external genitalia not developed. So what's going to happen is called male pseudo hermaphrodism, or hermaphrodism. Let me just write it down. Hard to pronounce. It's called male pseudo hemor. Okay, so this word. So what this basically means, that you have the genitalia at birth, you have internal genitalia is there, but the external genitalia is ambiguous, or of a female genitalia, because it's ambiguous. So that's what it results in. So again, let me just write it down. The genitalia at birth could range from a couple things. It could range from either the small phallus with hypospadias to even ambiguous genitalia, or even female genitalia. But the person, if you look at the chromosomes, is X and Y. A male is a male, but it does not have the genitalia, due to the fact that you have just a problem in one thing, which is 5-alpha reductase type 2. So you couldn't convert that in genitalia. You couldn't convert DHT. Now, with the problem, what's going to problem is going to arise is, because you have this. So when they reach the puberty, that's very important. Actually, when they reach puberty, what's going to happen that their skin type 1 5-alpha reductase will convert that, again, testosterone into DHT. Now they have a lot of DHT at the time of puberty. They will start developing their external genitalia. So again, at birth, they have ambiguous genitalia, or could be a female genitalia. But by the time they reach the puberty, they have a lot of levels of DHT, and that DHT will cause external genitalia to develop, and that's when they get the identity. Okay. So let me just summarize this part. So these childs, these childs are raised as females, or if they have ambiguous, they're raised ambiguously until puberty, during which their increased testosterone will convert into DHT through the skin, type 1 5-alpha reductase, which will lead to a couple things. For example, DHT also causes masculinization, also causes voice deepening, penile and scrotal growth, and testicular descent. All of that will happen at the time of puberty. Okay, so this is with the 5-alpha reductase type 2 deficiency. Okay, let's erase all this and talk about some more things. Okay, let's just take a look at the hormones, and we will then look at the enzyme deficiencies. So all you have to remember is you have a 17 alpha, 21, and 11 beta. So the way it is, you have, this is 17, this is 21, and this is 11. I think they have a mnemonic. Let's actually read their mnemonic. Well, actually, it's just for the hypertension. So just remember, whenever you're going on the right side all the way towards the right, it's going to be 17 alpha hydroxylase. Then you have 21 if you're going from let's say from progesterone into formation of your deoxycorticosterone or deoxycortisol. So everything deoxy needs 21 hydroxylase. Deoxy needs 21 hydroxylase. 11 beta is the one which actually forms a proper hormone. So 11 beta is the proper hormone. Okay, so with that, let's just look at the deficiencies, and then it's going to make sense. Okay, here what we have here is going to be your 17 alpha hydroxylase. 17 alpha hydroxylase is, as you know, that it is everything going towards the right side. So when you are deficient in 17 alpha hydroxylase, let's just first take a look at the picture. Makes sense. You don't have 17 alpha hydroxylase. When you don't have 17 alpha hydroxylase, everything is just going in formation of aldosterone. Okay, so there is going to be, because you can't go right, so you have no fasciculata hormones or reticularis. All you have is a lot of aldosterone. Everything will back up formation of aldosterone. So here, so you have mineralocorticoids. You have decrease in aldosterone, an increase in 11-deoxycorticosterone. What is this? Let me read one more time. 17, what did we talk about? We said 17, there is a deficiency of 17 hydroxylase. When it is deficient, why do we have a decrease in aldosterone here? Okay, let's just skip this part. I'll come back to this, but let's look at what's going to happen as the functions of it. So if you recall, what is the function of aldosterone? Well, the aldosterone, let's just write the function of aldosterone, and then we will understand what the potassium blood pressure is, what's happening with these guys, right? So aldosterone increases, aldo, let's just say, aldo increases renal sodium reabsorption, which increases sodium reabsorption, which leads to increase in blood pressure, right? Because wherever sodium goes, water follows. So when you reabsorb your sodium, the water is going to follow, and it is going to cause increase in blood pressure, which is essentially known as hypertension. That's one thing. But also aldosterone dumps out or secretes potassium and hydrogen ions secretion into the renals, causing low potassium levels. That's just normal physiology of aldosterone, okay? And because it's also dumping your hydrogens, it's going to cause metabolic alkalosis. Metabolic because it's the kidneys, alkalosis because you're losing acid. So it's going to cause metabolic alkalosis. Okay. That is just the normal physiology of aldosterone. So with this, let's take a look at 17 hydroxylase. So 17-hydroxylase deficiency, they have mentioned that you have decrease in aldosterone. Why is that? I have no clue. But okay, maybe, well, I mean, I will take a look at that. But maybe because aldosterone, we need angiotensin 2 to work and form aldosterone. So when you have a lot of aldosterone, because essentially if you look at the rest of things, it's just the high level of aldosterone, which is low potassium, increase in blood pressure, right? Let's actually take a look at another book. I'm going to open another first aid, see if there's a problem here. Give me 1 second. Congenital adrenal hyperplasia. Congenital. Okay, yeah. Okay, I was right. Here we go. Let me just open this up. Okay, here. This is another version of this. Actually, previous version of first aid. So here, absolutely, you have increased, because that doesn't make sense. So this doesn't make sense that you have decrease in aldosterone, because, I mean, it's a simple thing that when you have, I mean, wow, when you don't have 17-alpha-hydroxylase, meaning you can go there. So the only thing that all of that is going to cause is everything will shuttle down to the formation of aldosterone. This is as simple as it gets, right? Simple. That is why. So this is the new one, right? 2025 version. And I guess there's a problem here, which is they were saying it has decreased aldosterone, which is not the case. Now, this is the old version. You have mineralocorticoid. Mineralocorticoid is an aldosterone. Mineralocorticoid is aldosterone, okay? And glucocorticoid is cortisol or cortisone. So you have increase in mineralocorticoid, meaning you have increase in aldosterone. And that increase in aldosterone will cause low potassium, because it's going to dump out that potassium, high blood pressure because it's going to reabsorb that sodium, and decrease in cortisol because, again, we are not going on this side. When we're not going this side, we will not form all of this, and we will not form anything here. All we are going to form is this side, which is going to be, you have low cortisol, low sex hormones, labs, you have decrease in androstenedione. Right here, you have a decrease in androstenedione because nothing is made over there. So let's go back to our book. Here we have the new version. Okay, so this, forget this part. So just remember that you have increase in mineralocorticoid, which is increase in aldosterone, increase in aldo, increase aldo. Again, simple thing. Aldo, normal function, sodium reabsorption in the kidney. So you have increase in blood pressure because as the sodium follows, you have, whenever the sodium goes, the water follows, right? So you have increase in blood pressure, causes hypertension, which is blood pressure rise. Potassium, you're losing potassium with the high aldosterone. So low potassium, you're also losing hydrogen ions. That's going to cause metabolic alkalosis because it is acid. Okay, thank you, Dr. and Judith in FA 2022 is also aldo increased. Great, because this is total mess up. I mean, I'm reading this right now. This does not make sense. Okay, doesn't make sense. So we need a errata for 2025, and here's the problem in this book. Okay. Okay, so here, simple, guys, very simple thing. All you have to know is where the hormone is. Because you can't go this side, you cannot form cortisol. You can't go this side because this the same hormone. You can't form this. So guess what's going to happen in labs? You have decreased androstenedione, which is right here. You don't have that. So in the presentation, if it's a male, it's going to present as atypical genitalia because you don't have sex hormones. Atypical genitalia, undescended testes, no sex hormones. How come? You can't have that, right? In a female, you're going to lack secondary sexual development because everybody's normally the dominant is female unless you have the sex hormones which convert everything into those into the genitalia being formed and formation of testes. And here with the female, you just can't make the secondary sexual development. With the 21, so let's change color. 21 here. So when you can't, let's erase all this. When you can't have 21, now all of this will funnel down into the side, right? Because you cannot convert these guys here. So everything will go where? On the right side. So you have decrease in mineralocorticoids. When you have decrease in mineralocorticoid, which essentially means aldosterone, normal job of aldosterone was to throw out that potassium. You can't throw that out. It's going to be increased. Normal job of aldosterone was to have a high blood pressure, if it is a high level of aldosterone for sure. But here you have a low blood pressure and you have low cortisol because you're not making aldosterone now. You're not making cortisol. So both of these are low. Only one thing is high. That's going to be your steroids. With that, because you're not forming aldosterone, your renin will keep poking angiotensin 2 to make aldosterone. So your renin activity will go high. Your 17-alpha hydroxyprogesterone is going to go high because if you look up top, because you're not making anything at here, this guy will go high. There's going to be high level of 17-hydroxyprogesterone. So here, which is mentioned here, increased level of hydroxyprogesterone. What's going to happen with presentation with 21 hydroxylase is most common. Okay, this is most common enzyme deficiency. It presents in infancy, which is salt wasting. The patient is going to present with in infancy with salt wasting because if you recall, aldo was doing what? Sodium retention. When you can't have sodium retention, you have all that sodium going into the urine, causing salt wasting, okay, or childhood precocious puberty, which is because of all of that high level of sex hormones are going to cause childhood precocious puberty. In females, it's just virilization. In females, it's just going to be virilization. Now you ask, what is virilization? Virilization is basically women develop male pattern hair growth and men masculine features. So let me just write it down. Virilization in women is going to be that woman will develop hair pattern, male pattern hair growth. One thing. Second thing, they will undergo a masculine looks. That's the virilization in females. Okay. What else we have? Okay, let's add one more thing that is going to be about ACTH, which I've seen. So we need to put an ACTH here. Let's say ACTH. Like what's happening to the levels of ACTH. So here, because you have, let's just say here, ACTH is going to be high. Why? Because what you are trying to do is that your normal cortisol, if you have a cortisol, normal job of cortisol is to inhibit ACTH as a negative feedback, right? So when there is no cortisol, the ACTH will be like, hey, we need cortisol. Go to the adrenal cortex, stimulate the whole thing so that we can get that cortisol, right? But this guy doesn't know that, hey, there's a problem in the whole adrenals that you don't even have the enzyme. So the ACTH level is just going to go high, trying to get increased level of cortisol, which it won't get, but the levels are going to be high whenever you have decreased cortisol, because again, ACTH will come down to increase cortisol. We don't have the enzyme for that, so you always have a low cortisol, but the ACTH level is going to be high. Okay, and the last one here is going to be your 11 beta hydroxylase. With the 11 beta hydroxylase, what we have is, let's just first take a look at image again. So you don't have this enzyme, 11 beta hydroxylase. When you don't have this enzyme, although you have something here, and everything will also go back up into the formation of more and more androgens. So let's take a look. Here we have decrease in aldosterone. For sure, we don't have aldosterone. Increased level of 11-deoxycorticosterone. And if you look, you have increased level of deoxycorticosterone because you have blocked this enzyme here. And because you don't have aldosterone, same thing. But now if you look, this is very important. If you look at blood pressure and your potassium, they look like, hey, they are getting aldosterone. But that is due to the fact that you have a weak, like I talked about when I was saying all these points, that you have a weak mineralocorticoid activity within this enzyme. Within this byproduct, which is 11-deoxycorticosterone, has a weak aldo activity. Because you have a weak aldo activity and you have so much increased level of this 11-deoxycorticosterone, which has a weak aldo activity, although you have low aldosterone, but because you have this weak aldo activity and this enzyme is you have a lot of levels of this, it's going to cause as if you have increased aldosterone, which is throwing out that potassium, reabsorbing that sodium, causing increase in blood pressure. But the cortisone, which if you recall, this was the weak cortisone, as the name suggests, corticosterone, weak cortisone or weak cortisol. You don't have that, so your cortisol level is going to be low. And that is going to cause what? That is again going to cause increased level of ACTH, because ACTH wants to secrete cortisol, but it's not getting it, so it's going to be increased. Sex hormones, because everything is just going either formation of this, or it's going all the way formation of androgens, because you can't really go down, you can come here. So it's going to cause increase in sex hormones. But since you are getting aldosterone activity, so you have a decreased renin activity. Again, decreased renin activity as comparison to the increase in renin activity when you had no aldosterone. Okay, the presentation is going to be, in infants, you will see severe hypertension. Again, why? Because you have this aldosterone, which will cause increase in blood pressure right here. So hypertension. Or childhood precocious puberty. Again, because you have sex hormones, it's going to cause precocious puberty. Again, in females, it's going to cause virilization, which is deepening. You have masculine looks, you have male pattern hair growth, and that is what you see with this. Okay, now let's take a look at mnemonic and finish this topic. So if you look at all the congenital adrenal enzyme deficiencies are autosomal recessive. So all of these are AR, autosomal recessive, one thing. Second thing is, and most are characterized by skin hyperpigmentation. And if you recall, why do we have that? We said when you stimulate that POMC, that is going to cause increase in MSH, which is co-secreted or co-produced and secreted with ACTH. So all of these are causing, since we talked about here, ACTH, we said everywhere it's high. In the first one high, second one high, last one high, everywhere we have ACTH high. Why? Because everywhere we have low cortisol. No matter what enzyme we're talking about, we have low cortisol. Okay. So that means indirectly we have increase in ACTH. Whenever we have increase in ACTH, that is the ACTH is co-secreted by MSH and also beta endorphins. But MSH is going to cause hyperpigmentation, and that's what we see. So all of these AR, autosomal recessive disease enzyme deficiencies, will have hyperpigmentation. Okay. And not only that, but also bilateral adrenal enlargement. So you have bilateral adrenals on top of kidneys. These are going to be enlarged, okay, because of increase in ACTH stimulation. Okay. Now the second point is that what is B? B results in increase in blood pressure. Okay, yeah, here, which is the 11-deoxycorticosterone, which is a weak aldosterone. It is just going to cause increase in blood pressure. Okay. The last is, if that's the mnemonic now, if the enzyme deficiency starts with 1, it's going to cause hypertension. So 1 HTN 1, right? So if deficient enzyme ends with 1, it's going to cause virilization in female. So let's look at that. So we said if it starts with 1, so 1 is 17 and 1 is here. If it starts with 1, it's going to cause hypertension. Here is the hypertension. Here is the hypertension. If it ends with 1, which is only 1, which is actually 2 of these actually, it causes virilization in females. So 21, 11, virilization. Okay, that's one of the mnemonics. The second mnemonic, another mnemonic, what you can think of is all of these are going to, which I talked about just now, all of them are going to cause decrease in cortisol. Decrease in cortisol, meaning you have increase in ACTH, meaning you will have hyperpigmentation. That's one important point for all of them, right? Now, other thing that you're going to think of is the ones which are causing hypertension. And you can just think, hey, hypertension is caused when you are retaining sodium, right? So the potassium, there has to be something going on with potassium as well. Whenever you think of sodium or something, you got to think about potassium as well. So all of them which are starting with 1 will cause hypertension and loss of potassium. That's going back here. Let me highlight this part. Look here. Increase in BP, low in potassium. Increase in BP, low in potassium. This is only if you don't understand this. I mean, if you understand the whole point, I mean, the whole thing, if you understand it, I mean, you don't even have to memorize this. You would just know on top of your head that, okay, if you block this, if you block 17 out, all you're getting is aldosterone. What is the normal function of aldosterone? Hypertension, low potassium. You're not making any cortisone. You are going to cause increase in ACTH and increase in cortisone. You're not making any aldosterone. I mean, androgens, my bad. When you're not making any androgens, you're going to lack the secondary sexual characteristics in females, and you're going to lack genitalia and androcentesis in males. Okay, it's just the way when you think about it. Okay, if you think about the other way now, if you think, okay, your 21 hydroxylase is out. When the 21 hydroxylase is out, everything is funneling down into, first of all, your androgens. So you don't have any aldosterone, you don't have any cortisol. All you have is androgen. So what's going to happen is that you will have, first of all, increase in renin activity because you need aldosterone. So renin is going to poke this angiotensin 2 to cause increased aldosterone, which it will not be able to because there's an enzyme deficiency. So you have increased level of renins, but also you have increased 17-hydroxyprogesterone, which is right there, right? And lastly, what you are going to get because of a lot of those sex hormones being there, it's going to present with precocious puberty. Whenever you have a lot of sex hormones, it's going to cause precocious puberty in child and virilization in females. With the second point that I wanted to mention here, with the 1, whatever ends with 1 will cause virilization in females, and it is going to cause precocious puberty in a child. Okay, hope it makes sense. Okay, there's also something called as newborn. Newborn undergoes screening for 17-hydroxy progesterone. So let's just write that down. Newborn, they do screen the newborns for 17-hydroxy progesterone here. This guy, 17-hydroxy progesterone levels. Okay, and just a normal thing about the testes and ovaries. If you recall, the testes, they have two cells, right? Which we did talk about when we talked about FSH and LH. But here again, Sertoli cells and Leydig cells. Sertoli cells secrete MIF, which is going to cause inhibition of internal female genitalia. And what is internal female genitalia? All the ways start from the proximal vaginal canal, then the cervix. Okay, and that's job of MIF, Mullerian inhibitory factor. Leydig cell, on the other hand, it releases testosterone. That testosterone is going to stimulate internal male genitalia, and this testosterone, when converted into DHT, will form external male genitalia. Okay, and this is all about testes. Now let's talk about ovaries. Ovaries, when you have the ovary, you don't get MIF, because MIF was just getting from the Sertoli cells. So no MIF, which is Mullerian inhibitory factor. When no MIF, meaning no inhibition, you're not inhibiting any internal female genitalia. So you will form a proximal vaginal cervix and tablet uterus. And estradiol now here with the ovaries. So testes are forming, they're leading to release of testosterone, while the ovaries are releasing estrogen or estradiol. This estradiol is going to form external female genitalia, which is distal vaginal canal. Okay, this again we will talk about in the reproduction. With this, I guess that's pretty much it. And maybe I could add a little bit of. So since we did talk about all of the internal and external genitalia, let's talk about a little bit of the sex hormones. Sex hormones, for example, testosterone or anything, estradiol, all of them, right? Androgens. So these guys, if they're low, for example, in the first disease, 17 alpha, there are low sex hormones. So what's going to happen is you have male. If the patient is male, they are going to go into ambiguous genitalia, and the female will have no secondary sexual characteristics when they're low. When they're high, they are going to cause precocious puberty in the infants. And what is precocious puberty? Basically, acceleration of linear growth in child and pubic and axillary hair development in a child. Okay, before the puberty hits, you already have the puberty features, basically, right? And virilization in females. Again, as we said, this is important to just sex hormones when they're low, ambiguous genitalia in male. And in the females, no secondary sexual characteristics. Simple. When they're high, precocious puberty in child, and in females, virilization. Hope it makes sense. And that's going to be all for this page. Let's move on to the next one. Okay. All right, now let's talk about the cortisol. Cortisol, the source is zona fasciculata. So you had a G, an F, and R. So F is the one. So G gives you aldosterone, F is for cortisol, R is for androgens. So the cortisol coming from the middle layer, fasciculata, it causes a couple things. The very important thing is just remember this mnemonic and you should be good to go. A big fib. So the way you need to know is increased in a big, but a fib is decreased. Okay, so let's talk about it. Increase in appetite, increase in blood pressure by upregulating alpha-1 receptors on the arterioles, which then causes increased sensitivity to that norepinephrine and epinephrine permissive action. At higher concentration, at higher concentration, can bind to even mineralocorticoid aldosterone receptors. Wow. Amazing. Right. Second thing, increase insulin resistance, diabetogenic, which if you recall, we talked about cortisol growth hormone, and there was one more. These were all anti-glucagon, all anti-regulatory hormones, my bad, all counter-regulatory hormones, which are diabetogenic, insulin resistance. And the other hand, all you had is just one insulin, which was trying to get that glucose out of the bloodstream, right? So this cortisol, that's why the name goes glucocorticoid. It causes glucose to go into the blood vessels, so causing insulin resistance, diabetogenic. The way it causes insulin is to go into the blood. It's the same way, which increase in gluconeogenesis, increase in lipolysis, increase in proteolysis, and decrease glucose utilization. Now the fib is all decreased, high yield, decreased fibroblast activity, which causes poor wound healing, decrease in collagen synthesis, which leads to formation of stria, increase in stria formation. So when you don't have collagen, the vessels break, leading to formation of stria. Okay, decreases inflammatory and immune response. A high yield that the cortisol decreases inflammation and immune response, inhibits the production of leukotrienes and prostaglandins, inhibits WBC adhesion, leading to neutrophilia. Right? Neutrophilia, not neutropenia. Neutrophilia means increased level of neutrophils. And why is that? Because if you recall, neutrophils, they're like bats. They go into the not kidneys, but lungs, and they are just there upside down, right? And as the inflammation goes, they go there into the inflammatory side. But when you don't have the adhesion, because you give cortisol, you can't have the adhesion molecules through which the neutrophil adheres or are joined to the structure. Now they can't have that adhesion, causing all those neutrophils to go in the bloodstream, causing increased level of neutrophils. Blocks the histamine release from the mast cells. Eosinopenia, meaning low eosinophils. Lymphopenia, low lymphocytes. Block IL-2 production. Now recall, what is IL-2 doing? IL-2 leads to inhibition. Let me just write it here. IL-2 causes inhibition of T lymphocyte proliferation, T lymph proliferation. That is why glucocorticoids are used to prevent the rejection of transplant. So again, rejection of transplant is done by T lymphocytes. You try to inhibit IL-2 production. You try to block that IL-2 production to prevent rejection of transplant by giving glucocorticoids. Okay. And then you have decrease in bone formation, because causing decrease in osteoblast activity. Osteoblasts were the one which were formation of the bone, which form the bone. When you decrease their activity, you're just going to cause decrease in bone formation, leading to osteoporosis. Okay. Why one more thing which is not mentioned here is something known as lipocortin. Let's just write it here. So it inhibits production of leukotrienes and prostaglandins by synthesis of lipocortin. Lipocortin, all the lipocortin does is it inhibits that enzyme that is known as phospholipase A2. Phospholipase A2. And what is phospholipase A2 doing? All it was doing was converting arachidonic acid into your prostaglandins and leukotrienes, which are here. Leukotrienes and prostaglandins by the phospholipase A2 enzyme, right? And this is a very simple thing. But now this is a new thing which is known as lipocortin or lipocortin. So these guys, cortisol causes lipocortin increases or causes increased level of lipocortin, which inhibits this enzyme so you don't make prostaglandins and leukotrienes. Okay, so again, but high yield point, which is again not mentioned here, that is going to be that you need cortisol. It is essential for in response to stress. So essential hormone in response to stress. Essential. Okay, going back at this cortisol, it is bound to corticosteroid binding globulin. Okay, cortisol is a big fib, but it is increased and that fib is decreased, and you have seen that here. Exogenous glucocorticoid can cause, if you give someone from outside exogenous glucocorticoid, it will cause reactivation of tuberculosis. Reactivation of tuberculosis and candidiasis, because exogenous glucocorticoid is also going to block that IL-2 production, and that IL-2 production and also TNF-alpha inhibition. So all of that will cause interleukin-2 production, and also the TNF-alpha inhibitors are, like for example, interceptor are going to do the same. So let's just write that TNF-alpha inhibitors. Okay, so now looking at how we have the regulation is simple. So you have stress, as we talked about, it is essential in stress, and circadian rhythm, which causes the stimulation of hypothalamus. That hypothalamus then secretes CRH, corticotropin releasing hormone, and that causes stimulation of anterior pituitary, which converts again POMC. Here's the POMC, pro-opiomelanocortin, POMC, to get converted into formation of ACTH, but not only ACTH, but also MSH and endorphins. MSH is going to cause hyperpigmentation. ACTH will go into the core and into the cortex, adrenal cortex, into the lead to formation of cortisol, and that leads to cortisol. When it is out, it causes inhibition of hypothalamus, which leads to no release of ACTH. That is why previously we discussed that cortisol, when you don't have cortisol, there is going to be more and more production of ACTH, because all they're trying to do is have that cortisol to give a negative feedback, which they're not getting. So they will make more and more ACTH to go and make cortisol. Okay, and then cortisol is just going to do its downstream cortisol functions, which are a big fib or a big fib. Okay. So let's look at the same regulation here. And that is that CRH in the hypothalamus, corticotropin releasing hormone from hypothalamus, stimulates ACTH release from pituitary, causes cortisol production in adrenal zona fasciculata. Excess cortisol decreases CRH, ACTH, and cortisol secretion. So a simple thing, when you have a lot of cortisol, you're giving negative feedback, low CRH, low ACTH, and eventually causing low cortisol secretion. Simple. Chronic stress may induce prolonged cortisol secretion. Cortisol resistance can occur. Impaired competency can occur. Dysregulation of HPA axis. And that is also important. One thing that they haven't mentioned is that the cortisol, when it is down here in the bloodstream, it also causes a couple things. First of all, the cortisol also converts norepinephrine to convert that norepinephrine into epinephrine by stimulating enzyme PNMT, stimulated by cortisol. So more and more epinephrine due to the fact that you just have cortisol. Cortisol stimulates the conversion of norepinephrine to epinephrine. That's important. Second thing is going to be when you have low cortisol, it is the function with the ADH. So let's just put normal cortisol first. Normal cortisol is going to have two things. Normal cortisol, okay. It's going to, first of all, I just talked about, it's going to have increased level of epinephrine. And second thing is going to inhibit ADH as a regulation, as a negative feedback. When the cortisol is there, it tries to give a negative feedback for the ADH production. But again, this is normal cortisol. So guess what's going to happen when you have deficiency of cortisol? When you have deficiency of cortisol, you are going to have ADH because there's no negative feedback. And you also have increase in ACTH to cause more and more release of cortisol. Okay, let me see if there is anything. So one thing we mentioned here that was that in circadian rhythm, normal circadian rhythm will stimulate hypothalamus, causing release of cortisol, right? So night sleepers, just before waking up they will have the highest cortisol concentration. And what is it lowest? So just before they wake up in the morning, and I'm talking about night sleepers, okay? Just before they get up in the morning, because they have a proper circadian rhythm going on. So just before they wake up in the morning, they're going to have higher level of cortisol. And the lowest level they're going to have is at the midnight. And why am I talking about that? Because it's going to come up later in pathology. Midnight, they're going to have a lowest cortisol. And I guess that is going to be all for cortisol. So let's just go over this. We said cortisol coming from fasciculata binds the corticosteroid binding globulin. A mnemonic is a big fib, or however you want to call it. First of all, you got to know that a big is high and fib is low. So you have increased appetite, increased blood pressure by increasing, upregulating alpha-1 receptors, increased insulin resistance, increased gluconeogenesis, lipolysis, proteolysis. Now, everything else is just going to be decreased. Decreased fibroblast activity, poor wound healing, collagen is low. When the collagen is low, you have the breakage of the vessels causing stria formation, decreased inflammatory response, decreasing inflammatory immune response, but causing increase in neutrophils and decrease in bone formation because decreasing in the osteoblastic activity, which is osteoporosis. In inflammatory response, decreased leukotrienes and prostaglandins by synthesis of lipocortin or lipocortin. So cortisol, lipocortin, which inhibits the phospholipase A2, and that doesn't lead to formation of from arachidonic acid into prostaglandins and leukotrienes. You will not be able to make that. Other than that, you will have eosinopenia, lymphopenia, IL-2 blockade, and yeah, that's pretty much what we have. And yeah, that's pretty much, and you already know regulation. All right, the next thing we have is called appetite regulation. In the appetite regulation, we have a couple things. We have ghrelin, leptin, and endocannabinoids. So ghrelin, the first thing we have, it stimulates hunger. Right, simple. The mnemonic is very good. Ghrelin makes you grow hungry. Okay, so it stimulates hunger, simple as that. Orexigenic effect and GH release, growth hormone release via GH secretagogue receptor. Okay, so two things, hunger and growth hormone release. It is produced by where? By stomach. So stomach produces ghrelin. Sleep deprivation, fasting, or Prader-Willi syndrome increases the ghrelin production. So again, if you think about sleep deprivation, is going to cause release of ghrelin, which is going to make you grow hungry, which you eat, and cause GH release as well. Important, okay? We talked about mnemonic here. Ghrelin makes you grow hungry. X on the lateral area of hypothalamus, which is the hunger center, to increase appetite. Lateral area. So lateral area of the hypothalamus. Okay, important. The second thing is, okay, one more thing here is what else is going to increase ghrelin production? Well, it is starvation. So they mentioned fasting here, right? So starvation will increase ghrelin levels, and decrease in caloric intake will cause increase in ghrelin production, which essentially stimulates the hunger center, causing making you hungry, and also cause growth hormone release while acting on this lateral area of the hypothalamus. Okay, the second thing is leptin. Well, this leptin is the satiety hormone. Okay, it is produced by adipose tissue. So adipose tissue produce leptin, which produces satiety. Mutation in the leptin gene causes severe obesity. So satiety is like feeling full. Okay, I'm not hungry. But if you have a mutation here now you never feel full. You keep eating. You're going to cause severe obesity. Obese people will have increase in leptin due to increased adipose tissue. First of all, two things. Obese, they have increase in adipose tissue. And that increase in adipose tissue makes it increase leptin, but or tolerant. When you have a lot of level of something, the body gets tolerant to it. There are no more receptors for it. So body becomes tolerant or resistant to leptin, anoxygenic effect, which is basically satiety. Okay, sleep deprivation or starvation causes decreased leptin production. In other way, this is opposite. Sleep deprivation and starvation was causing increase in ghrelin production, which makes you grow hungry, right? Here, sleep deprivation or starvation is causing decrease leptin production. Okay, leptin keeps you thin. Leptin makes you thin. Acts on the VM, ventromedial area of the hypothalamus, which is the satiety center, to decrease appetite. Okay, so VM and lateral. So VM. So the mnemonic is going to be something like this. Ghrelin makes you grow laterally. So when you grow, for example, this is a normal person. When you grow, you're going to go laterally. You're going to get big, right? So ghrelin makes you grow laterally. So you can remember ghrelin works on the lateral nucleus of the hypothalamus. Okay. And leptin, the mnemonic for leptin is going to be that leptin is going to decrease the appetite. So it regresses medially. So leptin decreases appetite, so regress medially, which is VM. So if you know first one, the other one, you just know that it is ventromedial. The last one here is the endocannabinoids. Well, the endocannabinoids are they act as cannabinoid receptors in the hypothalamus and the nucleus accumbens, which are two key areas of homeostatic and hedonic control of food intake, which causes increase in appetite. Exogenous cannabinoid causes the munchkins. Okay, it causes the munchkins. Okay. So let's talk about a little bit of these endocannabinoids. Endocannabinoid, for example, endocannabinoids are marijuana. Okay. All they are going to cause is, again, increase in appetite. That's why they're called the munchkins. So the way they act is they act on the cannabinoid receptors. Again, where? In the same way hypothalamus. So all of these appetite regulations are in hypothalamus. So lateral, ventromedial, and cannabinoid receptors. And also nucleus accumbens here, a new thing here, nucleus accumbens. Two brain features which are homeostasis. They do the normal job of homeostasis and hedonic control of food intake. Okay, and leading to causing increase in appetite. Exogenous, like for example, marijuana cannabinoids can cause the munchkin. Is basically you're eating all the time. You're eating, and that is what we have. Okay, lastly, one extra thing that we are going to talk about is called the caloric restriction. So a lot of people go into caloric restriction diet, right? So caloric restriction will lead to weight loss. Let's just mention that. It does lead to weight loss. That weight loss will indirectly cause increase in ghrelin and decrease in leptin. Because weight loss essentially losing adipose tissues, you're decreasing leptin, but that weight loss, because you're going into starvation, you're increasing ghrelin, right? Normal physiology. That also, not only leptin, but also it will decrease insulin. Two things are decreased, one is increased, okay? And that will essentially cause increase appetite. So they will go into increased appetite. They will think about eating more. They want to eat more. And which makes it very difficult for a patient trying to lose weight, trying to go into caloric deficit, but the body is like, hey, what you are doing is not going to work. I'm going to send that girl in, which is going to make you grow. So their appetite is increased, which essentially is going to make difficult to maintain that weight loss. So essentially they did the weight loss in the first place, but later on in life, the weight loss is not there, or they regain the weight that they have lost due to the fact that normal physiology is what increase in ghrelin now, although because you have increase in ghrelin and you have decrease in leptin, and that increased ghrelin causes increase in appetite, which is right here, increases appetite. So one last thing, let's talk about here. One more thing is called leptin, right? Leptin decreases appetite, right? That's the normal function of leptin, but obesity will blunt this action. So let's just write it here. Obesity will blunt this action. So obese patient, now you ask, hey, let's just go back a step and say adipose tissues, because in obese patient we have a lot of adipose tissues. They're producing leptin. Why don't we have low appetite? Because obesity is going to blunt that action. And why? Because you have a lot of leptin in the blood the body is going to get tolerant to it. The body is not even responding to that leptin just due to the fact that you have a lot of adipose tissues, which is seen in obesity. So obesity is going to blunt the appetite function. Let's go over all of these and call it a day. Okay, again, very easy, but very important, okay? All we have is ghrelin makes you important mnemonic. Ghrelin makes you grow hungry. Simple. Okay, it's going to stimulate hunger and also growth hormone release. Sleep deprivation, starvation is going to cause increased ghrelin production. It acts on the lateral area of the hypothalamus, causing increased appetite. Leptin, on the other hand, comes from the adipose tissues, causes if there is a mutation in leptin gene, causes severe obesity. But the obese patient, although they have increased leptin due to the fact they have increase in adipose tissues, but they become tolerant and resistant to leptin. So that leptin does not work and does not decrease the appetite. Lastly, endocannabinoids, which act on the cannabinoid receptor in the hypothalamus and the nucleus accumbens, causes increase in appetite. And these guys, whoever is taking marijuana or any exogenous cannabinoids, they are known as the munchkins. They are eating. They are hungry all the time. They're trying to eat. One last point is about the caloric restriction, which causes weight loss. It does cause weight loss in the first place, but eventually the patient will go back to that. Why? Because you have a lot of ghrelin being produced, as seen here with the starvation and hunger. You're going to cause increase in ghrelin, and it will be harder for the patient to stop that increase in appetite. So they eventually will go back unless they're very determined, and that weight will come back. And it is very difficult to maintain that weight loss. And that is it. All right, guys. What are we going to do? Okay, so what we're going to do is, I guess that's it for the end of physiology. This is the next page is very simple one, but I guess we will just talk about that tomorrow. And let's call it a day. Thank you so much for all of you for joining, and see you guys tomorrow. Thank you.